Hello and welcome to Back to Fitness Week 2, the education sessions delivered to you from Southport and Ormskirk Joint Health Department. As we alluded to in Week 1, this week's going to be around pain, a little bit of the science behind pain, trying to make it as user-friendly as possible, and hopefully you'll gain some information and learn a few new things through listening to this short presentation. And then, as always, if you need any further information or questions, direct them towards the resources that are linked in or directly to us in department here. So as you can see up on screen, there's a definition of pain there from the International Association, and pain is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage or described in terms of such damage. And the most important thing that I want you to take from that is that the experience is associated with actual physical harm to tissues or potential harm or potential physical harm to those tissues. And that's the most important thing to take from that slide. We'll touch on that more as we go through. But the first kind of barrier to get over and help you understand the rest of the presentation is that pain does not have a direct relationship with actual tissue damage. Pain is a sensory experience that can be tuned up or tuned down, depending on lots of factors. Damage is a factor, but there's lots of other things that are also involved, and we'll touch on those as we go through and on to the next slide. So a little bit deeper explanation of the definition. Pain is not just a physical sensation. There is always an emotional experience associated with pain, and this can differ in everybody. This can be linked in with psychosocial things like fear or previous injury, but pain can be associated with actual damage like bruising and broken bones, just the same as it can be associated with potential damage when the body perceives a threat or a potential threat that could damage us, and we can experience real physical symptoms through that threat and through other avenues. Just because you can't see anything does not mean the pain is not real. The pain's always real. The pain is a physical experience, and we can never take that pain away from you as a feeling. But if you want to go into more detail around this association with pain and potential damage, there's a really good YouTube clip if you open a new YouTube tab on your home screen. And if you type in Lorimer Moseley TED Talk, that's Lorimer Moseley TED Talk, who's a pain specialist researcher and originally a physiotherapist. He's done lots of research into this potential tissue damage, and he explains it in a very jovial and informative way, better than I can anyway. So if you need any more information, please head over to Lorimer's video. So leading on from that, really, as I've said, we've studied pain in a lot more detail, and we understand things about pain a lot better now than perhaps we have in the past couple of decades. And this old model of pain is probably somewhere where a lot of our patients sit, and in all fairness, a lot of therapists probably sit before they do their research or their reading or their studying. So the old model of pain is that the painful stimulus, be it a burn, a cut, a fall, a broken bone, anything that causes that painful stimulus to be sent towards the brain to interpret, is directly equal to the amount of pain that the brain will then send back to that area and give us as a physical sensation. That also related to tissue damage. So we thought that tissue damage and the level of tissue damage, if you imagine a scale of 1 to 10, if the tissue damage was 1, the pain would relate to 1, and if the tissue damage was 10, then the pain would relate to 10. Now, we know that this isn't quite right. And we've been doing a lot of work around this and trying to explain why that's not true, because we know now that painful stimulus and tissue damage actually have no direct relationship with pain, and the physical pain that we receive as a human, or the physical pain that we feel as a human, has a lot more complex background than just a painful stimulus or just the tissue damage. There's lots more involved, and we'll go through that in a couple of slides time. But just in case you're thinking that we're not we're not barking up the right tree, then how can we explain this theory that pain and damage isn't quite linked up? Well, there's a few things that we can see which helps us contextualize it a little bit. Phantom limb pain, for example. So we work closely in hand clinic, orthopedic hand clinic occasionally, or in amputee clinics, or in spinal units where people have phantom limb pain, where their limb has been dismembered or removed, etc., and they're still experiencing physical pain in an area where they don't actually have a limb. So an example of this could be a farmer who's been moving cattle using big heavy machinery, gets his finger caught in one of the ropes, fingers completely dismembered from his hand at the knuckle, but then a few days later, after it's been stitched over, has excruciating pains on the outside, on the posterior part of his hand. And those pains have no biological or physiological reason to be there in terms of his anatomy, but he still experiences excruciating pain. Similar things can be seen in surfers and sharks with pain. If they know a shark's in the region, or they're particularly fearful of sharks being in the region, having pain on the moment of impact with the water is a real sensation that some surfers feel in the absence of any attack or any bites or anything like that. And the same with a nail in a work boot, in steel-toed or steel-based work boots. The thought of stepping on that nail can sometimes be painful. And if you think about a light-hearted example like standing on a piece of Lego or standing on a plug, then just the thought of that sensation can sometimes be painful. And if you imagine that in a fight or flight situation, then that symptom can be significantly sensitized. But that's not the be-all and end-all, and we'll touch on why this isn't bad news in a few slides time, and what we can do as human beings and what our bodies are good at in avoiding this or improving it. So if we think about pain, we normally generalize it into two categories of acute and persistent. Now, acute is the very clear-cut biological pain process that follows those healing and tissue healing processes that we know and study. So this is under 3 months, under 12 weeks. Normally it starts off with tissue damage, actual tissue damage following an injury, which then promotes an inflammation process, which then promotes a tissue healing process, the building blocks, if you like, laying down all those fibres that will create our healed tissue. And then normal fades back in after the healing has been completed, and function normally comes along with that. These are easier to treat by and large because that pain has a purpose, and the purpose is normally to protect the area that's been damaged. Once that length of time has been completed, the pain will fade away and functions return to normal. However, with persistent pain, it's kind of the opposite. So greater than 12 weeks, and at that stage there's no inflammation occurring, tissue healing's completed, there's no more collagen to lay down, the vascularization to that area is correct, etc. And what happens then normally is that the tissue gets sensitive. And these are always more difficult to treat because wherever this is in the body, there's no purpose for that pain in theory. So you're getting a consistent pain response from an area like your lower back. It's uncomfortable, it's painful, it's getting in the way of your daily function, and it can really wear people down when it's occurring for such a long period of time. So it's difficult to then try and think about why that pain's there, and if I've not got any damage, why am I experiencing it? And that's that sensitization process. And we'll talk about that in the coming slides. But most people that come into our Back to Fitness class are in that persistent pain phase. So how does pain really work? And if we draw from what we've learned already in this presentation, we know that it's not as simple as an injury and a painful response. And the peripheral nervous system, in tune with that, is not all that straightforward, but we're going to keep it nice and straightforward for you today. So the peripheral nervous system has several different forms of nerve receptor, which in a relatively self-explanatory manner receive information specific to their function. So mechanical receptors, for example, might detect a change in the mechanics in and around a part of your body, so a change in the muscle, the tendon, the bone, a break, something physical, a physical change. If that then promotes a huge inflammatory response and we get a big swollen part of the body, or it's red and hot, then that would obviously change your temperature receptors, and so on and so forth. But with nociception or nociceptors, these are the danger receptors of the body. And if you have a look at the video that I alluded to earlier on, this goes into a lot around this nociceptor danger receptor. And these nociceptors are a little bit more susceptible, if you like, to those secondary third-party influencing factors that we've been touching on throughout this presentation. So how the brain processes that danger or perceives that danger sometimes isn't always wholly accurate, and we can have experiences in our past, or we can have certain situations where that danger reception is slightly off, or it's slightly too high, and that promotes more of a pain response than something that we may previously have not thought would hurt all that much. But the peripheral nervous system's job essentially is to get information from the peripheries, from the out ends of our bodies, hands, feet, backs, legs, and then get it towards our central nervous system. In the central nervous system, the receptors receive enough stimulation. If they receive enough of this information where the body's perceiving danger or perceiving threat, then an action potential, essentially a very quick nerve impulse, is produced and then sent to the relay stations in the spinal cord and the brain. This all happens in milliseconds. The relay stations can be thought of like a telephone exchange, so some messages are passed on to the brain, some aren't, no further action is taken on some, and the brain is very clever at working this out and uses lots of information to work it out. But this is where it gets a little bit fuzzy, because this can change from individual person to person, and how the brain interprets this information can also change person to person. And these are some of those elements that can affect the brain's ability to process that information. Past experiences we've touched on a little bit. So if you've had a past experience that's been acutely painful or been very painful, naturally your brain is trying to avoid that, and you are trying to avoid that. But if your brain feels like the current situation is in any way similar to that past experience, it's likely to increase the pain response to further protect you, and knowing what it knows from when it might have happened in the past. Memory also works in a very similar way. If the brain maybe knows that the pain response wasn't excruciating, but the time following that was, so maybe it was a broken bone at the time, didn't feel awful, but then over a period of time became more and more painful, maybe there was complications post cast takeoff, then that memory can also play in to that area and make it more sensitive. And that sensitivity isn't long term. We'll touch on that in a couple of slides time. Stress also plays a huge role. So if we think about these pathways where information is being sent down, the more information that's sent down that pathway from the area that was causing pain to the brain is going to cause a bigger pain response. And if you're stressed about that pain, which is natural because pain is stressful, then the bad news is the more you're thinking about it, the likelihood is that you might be making it worse. And in fact, if we can stop thinking about that painful situation too much, maybe we can help that pain out. There's a couple of other things that can affect the severity or the interpretation of that pain. Your environment can definitely do that. So there's an interesting study that I read, which is basically a group of patients in a cold, dark room and a group of patients in a light room. The group of patients in the dark room have lower back pain complaints, and the group of patients in the light room don't have any pain complaints. They're blindfolded, and all that the researchers did was place a hot spoon on the back of the hand, not enough to burn their skin or cause any damage, and just ask them to rate that pain on a scale of 1 to 10 on a VAS scale. The group that were in the dark, cold environment and also had an existing pain complaint were explaining pain results of 7s, 8s and 9s out of 10. And the healthy population, if you like, that were in the light room with no existing pain problems were experiencing realistic pain responses of 1s and 2s. So that shows us that the environment and the situation we're in can significantly change our perception of pain, and beliefs can play a huge role in that as well. So for example, if you already think that a certain movement is going to be painful for you, the likelihood is that you'll tense up, You'll hold your breath and you'll make that situation even more uncomfortable than it has to be. But even a little bit more simply than that, if you don't believe that something is going to work, like pain relief or like analgesia, like exercise, like the class that you might be attending in our department, if you're not on board with it, then the likelihood is that you're going to slow that process to get better. And this information that we're giving you is all based on the scientific evidence, and it's all based on research. So it's important that if you have any questions or you have any queries, you don't agree with something, then you let us know and we'll talk it out maybe in a different way, or we'll get around it to make sure the information that you need is received in the right way. Okay, so you've heard us talk about sensitization quite a lot. It's probably a word that we throw around a little unsparingly, but the question really is, why do we have pain after an injury is healed? Well, the receptors, spinal cord and brain become more sensitive, as we've spoken about, and get better at running that painful cycle or that painful pathway. And typically in patients, we see that the pain lasts longer than tissue healing, as we've mentioned. Very small movements start to hurt, and that pain location can start to spread from a very pinpoint area to maybe a 10 centimetre radius or something larger than it first started off with, and it's very unpredictable. It doesn't really follow any pattern, and when we're taking a history off somebody with pain in the absence of a pattern normally suggests that there's something else at play, there's something else at work here. But the best way we can really describe it, similar to the pathway analogy, is if you imagine a motorway at 9 o'clock in the evening when it's really quiet, you might have 3 or 4 cars going down there every minute. And that's a normal painful pathway, information flowing to and from with no real traffic. And then if you imagine a sensitized pathway, the motorway at 9 o'clock in the morning, rush hour time, there's hundreds and hundreds of cars, or in this case hundreds of receptors being sent and messages being sent to and from the brain. And if that continues and continues and continues, you can imagine how overloaded that system will be with information, and then naturally the area becomes sensitized. And what we're trying to do is get that pathway to look more like the quiet motorway, to slow it all down and start to rationalize movement, locate the pain in a better way, and try to come up with some techniques around reducing your pain. And the good news is that we are neuroplastic. So neuroplastic means that the nervous system can remodel itself and become less sensitized, just the same way as it became sensitized in the first place. The brain has the ability to change and can become less smudged through that remodeling process. So the peripheral nerves become less sensitive and less responsive to that input that it was previously really responsive to. And gentle, controlled exposure with the help of your physiotherapists to those feared or avoided movements can help to change the beliefs and help change those other things like environment, and subsequently reduce the threat that movement is associated with your pain. Now, of course, this will be different in everybody because the levels of your pain and everybody listening to this will be completely different. But the main thing is that you are in control of it. Yes, we may need some help. Yes, it's going to take some work and it will be consistent and it's not going to be easy. There are going to be days when you think it's not working, but trust me, in the long term it will. You just need to stick with it with the help and advice of your healthcare professionals. But that is the most important slide on this presentation. We are neuroplastic, we are adaptive, and we can reverse this process. You just need to stay on board with us and trust us all the way through. Ask lots of questions, gain information, because the more you understand, the better you're going to be able to cope with your issue. And to conclude, the pain is always 100% real, whether it's acute, persistent, etc. The pain comes from the brain, not our muscles or tissues, and the pain doesn't always equal damage or harm. I'm not trying to tell you that you're making your pain up in any way, shape or form, because the pain is always real and pain is not nice. What we're trying to do is give you some empowerment over it, and hopefully this presentation has helped you understand a little bit more to do with that, alongside your exercise routine that's been given to you via our outpatient department. There's a few really nice, useful resources that you can have a look at. The Smiling Minds app is something we use in class, and it's a brilliant application to help with some relaxation and mindfulness. After exercise, it can be really useful, but in all honesty, it can be useful throughout the day at any point. So give that a download, have a read, or just have a quick Google of what it entails. It's a really, really good app, and I recommend it specifically for this population of painful patients. Or go and look at www.jointhealthmatters.org, where there's a wealth of information on pain management, local support for this, and of course, failing all that, or any questions, get in contact with us in department here by heading to the NHS website, Ormskirk and Southport, or speak to your physiotherapist directly. We'll see you next time.